Myself, Dr. Anushri Netli. I am starting this meeting on behalf of Maharashtra University of the Health Sciences and on behalf of Dr. Karthi ma'am. As she is busy in another meeting, so we shall conduct this meeting. And today's, as we are having the topic of respiratory system, and today's presenter is Mansi. Mansi, please introduce yourself and let's start your PowerPoint presentation.
Yes, ma'am. Yes. So good afternoon, all. Myself, Mansi Deshmukh, a second-year master student of the elective cardiovascular and respiratory physiotherapy from DES Brijlal Jindal College of Physiotherapy. On the behalf of our principal and faculty, cardiovascular and respiratory physiotherapy, I express our gratitude for giving us the opportunity to present a case in this online clinical meeting. So here I start with the case. Ma'am, is my screen visible?
Yes, it's visible.
Yes. Okay. So, patient descriptions. I am presenting a case of a 51-year-old female. She is a homemaker. Her build is mesomorphic, weight 62 kgs. Chief complaints, breathlessness on exertion since 3 weeks. Case history, patient was apparently all right 25 days back. She started experiencing cough with expectoration and breathlessness, which was gradually increasing. For this, she visited a nearby, just a second. For this, she visited a nearby physician who told her that she was not maintaining oxygen saturation and that she needs oxygen therapy and advised her to get admitted in a government hospital for further treatment. The patient visited the hospital with the complaints of difficulty in breathing and cough with expectoration. The cough was scanty, mucoid, and more in the morning. Breathlessness gradually progressed from grade 3 to grade 4 on MMRC scale. She also complained of diffuse chest pain at the time of coughing. After admission at the hospital, investigations were done. The ABG done on day 1, when the patient was on nasal prongs with 6-liter O2, showed that pH 7.42, PCO2 32.1 mmHg, PO2 97.2 mmHg, HCO3 20.8 millimole per liter, and base excess was minus 2.7 millimole per liter, suggesting compensatory respiratory alkalosis with adequate oxygenation with external O2 supplementation. Oxygen therapy was started. Now the patient is on nasal prongs with 1 liter O2 and has breathlessness only on strenuous activities, MMRC grade 1. Presently, the patient is under medical and physiotherapy management. So her course in the hospital, day 1, the day of admission in hospital, her O2 saturation was 86% on room air, 98% on nasal prongs with 6 liter per minute of oxygen. Day 2, 92% on NIV, BiPAP, FiO2 35% and PEEP 6. Day 3, 96% on NIV, BiPAP, FiO2 30%, PEEP 5. Day 4, 96% on NIV, BiPAP, FiO2 30%, PEEP 5. Day 5, 98% on nasal prongs, 3 liter per minute of oxygen. When the patient was evaluated, she was on nasal prongs with 1 liter per minute of oxygen and her oxygen saturation was 97%. Past medical history, pulmonary tuberculosis 25 years back, she had completed AKT, rheumatoid arthritis since 12 years, history of admission 3 years back in the same hospital for acute exacerbation of obstructive airway disease. Family history, the patient's father was a diagnosed case of tuberculosis. Drug history, injection Augmentin, injection PAN40, tablet prednisolone, tablet AZI 500, tablet CT2, syrup Cofarest, injection Hydrocort, nebulization with Duolin and Budecort. General examination, build of the patient was mesomorphic, breathing pattern, thoracoabdominal, use of accessory muscles of respiration was present, that is sternocleidomastoid and scalene muscles. Grade 2 clubbing was present. Ulnar drift of both hands, swan neck deformity of little finger bilaterally, boutonniere deformity of ring fingers bilaterally. Posture, she had a forward neck and protracted shoulders. Pallor, edema, lymphadenopathy, icterus, cyanosis was absent. Vitals, temperature, the patient was afebrile. Heart rate, 78 beats per minute. Respiratory rate, 16 breaths per minute. BP, 130/90 mmHg. Am I audible?
Yes, carry on.
Yes, ma'am. Yes. So, on palpation, the position of trachea was central. Tactile vocal fremitus anteriorly increased on the left side, 3rd to 7th intercostal spaces. Posteriorly increased on the left side, 4th to 8th intercostal spaces, interscapular and infrascapular region. Axillary increased on the left side, 6th and 7th intercostal spaces. Vocal resonance anteriorly increased on left side, 3rd to 7th intercostal spaces. Posteriorly increased on left side, 4th to 8th intercostal spaces. Axillary increased on left side, 5th to 7th intercostal spaces. On percussion, anteriorly, reduced note on left side, 3rd to 7th intercostal spaces. Posteriorly, reduced note on left side, 4th to 8th intercostal spaces, interscapular and infrascapular region. Axillary, reduced on left side, 6th and 7th intercostal spaces. On auscultation, breath sounds were diminished. Foreign sounds, fine crepes were positive, bilaterally, infraaxillary and posterior basal zones, left more than right. On examination, chest expansion reduced at 4th and 6th intercostal space. Chest excursion reduced on left side, upper and lower zones. Musculoskeletal examination, range of motion, full and functional, bilateral upper and lower extremities. Manual muscle testing, grade 4, bilateral upper and lower extremities. So the differential diagnosis we get to know as she may have post-TB fibrotic lung disease, or secondly, rheumatoid arthritis associated interstitial lung disease. Now we go to the investigations which will help us get a definite diagnosis. So her complete blood count, hemoglobin was 10.8 grams per DL, ESR was 38 millimeters per hour, RA factor was greater than 8 international unit per milliliter, anti-CCP test was done which was greater than 200 international unit per milliliter, chest radiograph, cardiomegaly and bilateral homogeneous opacity, USG suggestive of liver and renal parenchymal disorders, HRCT thorax, extensive areas of diffuse inter and intralobular septal thickening with surrounding ground glass opacities in apicobacillar gradient with areas of cylindrical bronchiectatic changes more over right middle lobe and lingula with few areas of honeycombing in right upper lobe. Features suggestive of ILD, UIP pattern, changes secondary to RA associated ILD. Mediastinal lymphadenopathy, multiple subcentrimetric and few enlarged pre-paratracheal, prevascular, bilateral hilar and subcarinal lymph nodes, largest measuring 2 into 1.3 centimeters in left hilar region. Most of them appear calcified. Atherosclerotic changes noted involving arc of aorta and coronary artery in form of wall calcification. Visualized bones show degenerative changes in form of osteopenia and osteophytes. Anterior wedge collapse of D12 vertebra noted, less than 50% vertical height preserved. 2D echo, left ventricular ejection fraction was 60% and no pulmonary artery hypertension. ABG, initial ABG showed pH 7.42, PCO2 32.1 mmHg, PO2 97.2 mmHg, HCO3 20.8 millimole per liter, base excess minus 2.7 millimole per liter. Interpretation, compensated respiratory alkalosis with adequate oxygenation with external O2 supplementation. As the patient was weaned, patient was on nasal prongs with 2 liter oxygen. That time the ABG showed pH 7.41, PCO2 48.4 mmHg, PO2 49.4 mmHg, HCO3 30.2 millimole per liter, base excess 4.5 millimole per liter. Interpretation: compensated metabolic alkalosis with moderate hypoxemia, external O2 supplementation. So we come to a diagnosis that the patient has acute exacerbation of post-PTB OAD with RA-ILD with type 1 respiratory failure under evaluation. We have the patient's X-ray here displayed on the screen. So the chest X-ray had an impression. It is a PA view. There are post-reticular opacities in left upper and lower zones and right upper and middle zones. Fibrotic cystic appearing lesions in left and right hilar region. Tramtrack parallel lines seen, left lower zone, lingula. Other visualized soft tissues and bones appear normal. Thank you. That's about my case, ma'am.
Yes, very well presented, Mansi. Now, to discuss this case, we have with us Dr. Komal Shah. She is senior pulmonologist in MUT Medical College. And for Ayurveda perspective, we have Dr. Gautam Kumar Jogat. He is HOD and a professor from Bhausaheb Mulak Ayurvedic College, Nagpur. So I request both of you, sir and ma'am, to kindly enlighten this case with both the perspective, both Ayurveda and medical. Dr. Komal Shah, ma'am, can you please share your opinion? Has Shah ma'am joined?
Hello, can you hear me now?
Yes, ma'am.
Yeah. So first of all, I'd like to say that very nicely presented case. So did I miss on the PFT part? Did she mention about PFT?
No, ma'am. Actually, I couldn't mention about the PFT. PFT was not done. We did not have the reports.
Okay, because when you are saying it was post-TB obstructive plus RA-induced restrictive, so it would be a mixed disorder rather than just plain restrictive lung disease. So your title here would differ. First thing. Second, she always had type 1 respiratory failure, right? She never had CO2 retention.
Yes, ma'am. She did not have CO2 retention.
And she was on any treatment for rheumatoid arthritis?
Intermittently, not continuous. Yes.
But what she had taken?
Ma'am, anti-inflammatory. Prednisolone tablets were on and off. Only during exacerbations.
Anything like methotrexate she was on before?
No, ma'am. No.
Okay. Why I'm asking you this? Because it can also lead to interstitial lung disease. So then at that time, you will not know whether it is secondary to RA or whether it is secondary to medications that she's been taking. Do you have CT scan of the patient, just pictures of the CT scan so that I can explain where is the honeycombing and things like that?
HRCT film is not available, just the impression.
Okay.
That
were my points. Anything else? Sorry, ma'am.
She has mentioned the report of HRCT, I think.
She did report. Yes, she did mention. That's why I wanted to know the plates so that I can explain them that where is the honeycombing exactly, how is it a UIP pattern. So when there is a UIP pattern that she has mentioned about the IPF, so what is UIP? It is undifferentiated interstitial pneumonia. Okay. So if when there is no reason for UIP pattern, it goes into IPF. IPF is when you don't know the reason. Or otherwise, it can be connective tissue disease, it can be RA, anything like that. So what is UIP pattern? UIP is when there is involvement of subpleural and basal part of the lung. Subpleura is just next to pleura, or base and base part of the lung. When there is honeycombing is like what we see the honeycomb. So honeycombing, interstitial septal thickening or reticulation. When these features are present, it is known as UIP pattern. And UIP could be present in either IPF or RA or connective tissue disorders or any other disorders. So here we know the cause, that RA factor was positive, anti-CCP was positive, and that is why she is categorized into RA-induced ILD. Plus, she had history of tuberculosis for which she was treated. So that's why she had TB-related obstructive airway disease as well. That is why this becomes the case of mixed obstructive plus restrictive airway disease.
Yes, ma'am.
That's it from my part. I have a presentation on restrictive lung disease also, ma'am. You want me to go through it or it's fine?
Yes, ma'am.
Yeah,
Can you
I was asked to make a small PPT on restrictive lung disease. Should I show it or it's fine? It's just a
Yes.
case discussion.
No, you should show your presentation.
Hello.
Please go with your presentation.
Okay, I need to share the screen first.
Please show your presentation. Please go with your slides. Yes, sure.
You can see now? Is it properly visualized?
Yes, madam, it is properly visualized. You can continue.
Okay, thank you. So the topic today is restrictive. Hello.
Madam, it's visible.
Okay, thank you. So the topic today is restrictive lung disease. Hello everyone, I'm Dr. Komal Shah. I'm Associate Professor, Respiratory Medicine from Vasantrao Pawar Medical College, Nashik. So basically I have made a very short PPT to let you know that what are the main types of lung disease, what are the characteristics of specifically restrictive lung disease, what are the causes of restrictive lung disease, how to identify restrictive lung disease by lung function test, and comparison between obstructive and restrictive lung disease. So basically lung diseases are divided into three groups. One is obstructive, which affects the airways. Another one is restrictive, which affects the lung parenchyma. And the third one is circulation, that is vasculitis. So when we talk about the restrictive lung disease, it again is divided into two groups. One is intrinsic and extrinsic. Intrinsic is something that affects the lung parenchyma, that is inflammation of the lung tissue, that is called as fibrosis. And when we talk about the extrinsic factor, that is external to the lung. So what are these factors? They are the extrathoracic, extraparenchymal diseases like thoracic cage disease like kyphosis, scoliosis. Then there are disorders affecting pleura like pleural thickening, pneumothorax, or neuromuscular disorders like respiratory muscle paralysis. So basically, restrictive disease is when the lung is not able to expand. Either it is due to intrinsic factor or extrinsic factor. Now, what are the intrinsic lung factors? Why the lung tissue is affected or lung parenchyma is affected? So there are multiple factors. Very common ones are occupational and environmental factors like silica dust, which causes silicosis, asbestos like asbestosis, radiation treatment, smoking can lead to lung tissue damage, medications like methotrexate, as I mentioned earlier, antiarrhythmic drugs like amiodarone, medical conditions like pneumonia, TB, arthritis, these all can lead to damage of lung parenchyma, which can lead to restrictive lung disease. And intrinsic factors, what do they cause? They cause pulmonary fibrosis when lung tissue becomes damaged and scarred. This thickened, stiff tissue makes it more difficult for lungs to expand, that I mentioned earlier. So now, if we see this graph, the lung volume in emphysema is much higher than the normal lung. Why? Because there is air trapping, because of which there is loss of elasticity. So the lung volume increases. But in fibrosis, what happens? That lung is not able to expand. And that's why the volume decreases. So what are the signs and symptoms of fibrosis? Because there is lung cannot expand, there is loss of oxygenation, like she mentioned in the case type 1 respiratory failure, which will lead to shortness of breath because patient needs to take more breath to get more oxygen. There will be dry cough due to irritation of the lung parenchyma. Patient will get fatigued because of more efforts of breathing because of hypoxia. There will be unexplained weight loss and muscles and joint pains. It can lead to further, because there is persistent hypoxia, which leads to vasoconstriction, will lead to pulmonary hypertension, right heart failure, respiratory failure, and sometimes these scars may lead to lung cancer. So what happens when there is change in the gas exchange? So there is difficult expansion of lungs that I mentioned. It reduces ventilation and reduces gas exchange, obviously. So because of that, there is increase in PCO2 and decrease in PO2. Hypercapnia and hypoxia lead to elevation of blood and reduces blood pH. So how do we diagnose? We can diagnose it with X-ray chest, lung function, the first and foremost clinical history, which is most important. Uske baad we can do other tests like chest X-ray, lung function test, CT scan, echocardiogram, and lung biopsy. In the case that she presented, there was RA-induced ILD, and that's why we could see the areas of fibrosis. But when it comes to extrathoracic restrictive lung disease, we can see something like pleural effusion, pneumothorax, or we can see the shape of the spine in case of kyphoscoliosis and things like that. CT scan will help us in confirming the diagnosis. So here is the PFT which I was talking about. So when we look at the PFT, because lung is not able to expand, the FEV1, the forced expiratory volume in first second, and FVC, forced vital capacity, both will be reduced. So there will be reduced in total capacity, there will be reduction in vital capacity, forced vital capacity, and FEV1. But because FEV1 is also reduced and FVC is also reduced, the ratio will remain normal, which is opposite to obstructive airway disease. What happens in obstructive airway disease that because of the air trapping, the first second, that is FEV1, will reduce more in comparison to FVC. And that is why the ratio reduces. But in restrictive lung disease, the ratio remains the same. So here you can see that in restrictive lung disease, the ratio remains 0.95 because FEV1 has also reduced than normal and FVC has also reduced proportionately. That's why. So here you can see clearly that in obstructive airway disease, FEV1 reduces out of proportion to FVC. And that is why the ratio reduces. Here, both reduce proportionately. That's why FEV1 by FVC is normal. However, the compliance reduces and elasticity increases. This is the graphical presentation of the same. So what are the treatment? So treatment obviously is according to the disease. So if there is RA, we will treat RA. If there is something like IPF, we do not have much of the treatment, but we can use antifibrotics like nintedanib, pirfenidone. Pulmonary fibrosis cannot be reversed. Some treatment reduce the symptoms and slow the progress of the disease, like as I mentioned, antifibrotics, but it cannot reverse the disease. Initially, when there is something like chronic hypersensitivity pneumonitis or acute hypersensitivity pneumonitis or AIP, in those cases, we may give a trial of corticosteroid. In this case, we will see some ground glassing in the CT scan and X-rays. That means it is the active process, which we can treat with corticosteroids. But once the fibrosis develops, we cannot do anything with the steroids and we should not be giving steroids. Sometimes combination with other drugs suppress the immune system like cyclosporine. So this can be given in initial phases only. Oxygen therapy, obviously, when the patient is hypoxic, we have to treat with oxygen. That's it. Thank you.
Yes, ma'am. Thank you so much. Very well easily explained about this certain topic. Now I request Dr. Jogad sir to please throw the light on this topic by Ayurvedic point of view.
Good afternoon, all participants and faculty who joined today's webinar organized by MUHS. And a special thank you all organizing team for inviting me and allowing me to share my views regarding respiratory system and Ayurveda. Madam, please allow me to share the PPT.
Yes, sir. Yes, sir. You can share.
Yeah, ma'am, just a minute. Are you able to see
Yes,
PPT, ma'am?
sir. Yes, it's visible. Yes.
Okay,
Please
today
continue.
very nice case presented by Dr. Mansi Deshmukh, and in very short but swift manner, Dr. Komal Shah presented about the restrictive lung disease, how to diagnose and how to treat it. So I'm going to share with Ayurvedic point of view. So in Ayurveda, respiratory diseases are described under the head of Rajyakshma, similar to tuberculosis, then Urakshat, Shosh, Shwas, and Kas. These are the diseases mentioned in Ayurveda. This today presented case was of tuberculosis. In Ayurveda, tuberculosis means it comes under the disease called as Raj Yakshma. So it is described in another way. This is the etiopathogenesis of tuberculosis mentioned in Ayurveda. It is mentioned under the head of Anulom Kshay and Pratilom Kshay. Due to the Sahas or Kshay, Shukra Dhatu Kshay, or all Dhatu depletion of the all Dhatus in Pratilom manner or in Anulom manner. Finally, it results into Raj Yakshma, that is called as tuberculosis. So these are the Samprapti Ghatak, means pathogenetic factor mentioned in Ayurveda for tuberculosis. Dosh involved are Kapha Pradhan dosh. Sometimes Vata dominated diseases are also present in tuberculosis. Dushya mentions are all types of dhatu, rasa, rakta, mas, med, all 7 types of dhatu by which our body is constituted. So all are involved in tuberculosis indirectly. Though symptoms are present in respiratory system related, but all body is involved in Rajyakshma or tuberculosis. The state of Agni means digestive fire is weak, that is called as Mandagni. So metabolic, we call it as metabolic dysfunction, Dhatvagni Mandya. Strotas involved, all strotas are involved in it. And Adhistan and Vyaktistan means the site of presentation is mainly respiratory system and other body parts also. So whenever we give the ADR, means anti-tubercular drugs, anti-tubercular, there are chances of adverse drug reaction. These are mainly present adverse drug reaction in tuberculosis patient at the time of the treatment of AKT. Mostly hepatitis, then metallic test due to the drug and due to disease also, then vestibular toxicity, peripheral neuropathy, optic neuritis, GI disturbance, diarrhea, flatulence, and back pain, chest pain. So these are the adverse drug reaction mentioned according to the drug and their adverse drug event on body. So I will not go in detail of this, but these are the main adverse drug reaction which we encounter. So it is a bit challenging for us to treat a patient or to give the medicine for 9 months or 1 year to these patients. Sometimes patients stop the medicine due to this adverse drug reaction, like metallic test of the drugs or depression. Then peripheral neuropathy is the very one challenging questions. So in these cases or in this case, Ayurveda can help as an adjuvant therapy. You can zoom to see this case. This is a PubMed published cases. I intentionally going to share it here. In this first case, Dr. Vyas treated the 133 TB patient with Rasayan drug in the form of capsule. And he found it is very effective. It is given with the control group and it is very effective in cough, then fever, dyspnea, hemoptysis, and increase in body weight with highly statistical significance. The Rasayan drug, which is given as Amalki, then Guduchi, then Ashwagandha, very well known drug, everybody is aware of it. Then ST Madhu, Pippali, Kushta, Kulinjan. The combination made from these drugs were given to the 133 patients of the tuberculosis. Then the second case was by Dornala and Dornala. He treated the 60 patient, sputum positive CAT1, CAT2 and CAT3 category. Along with the AKT, he has given the patient Bhrungaraj, liquid Ayurvedic preparation, which is prepared from Bhrungaraj. And it is found it is very effective in all kind of CAT1, CAT2, 3 patient. Then the third study, which is published in PubMed Journal 2012, drug given Ashwagandha and Chyawanprash. Total 99 patients were undergoing anti-TB treatment were given this combination Ashwagandha and Chyawanprash, and it is found highly effective. The symptoms subsided, body weight showed improvement. Usually at the time of AKT, patient loses body weight. But if we give Ayurvedic medicine along with it, there are chances of weight gain also. ESR values were normal. There was an appreciable change in immunoglobulin A and immunoglobulin M patterns, significantly increased the bioavailability of isoniazid and pyrazinamide. It is also challenging to increase the bioavailability of this drug, and certain Ayurvedic medicines are also helpful in these conditions. Then the fourth study conducted by Dr. Sharma, and he has given Liv 600 capsule. It is a combination of certain Ayurvedic medicine along with the Bhumya Malki. This is very good medicine mentioned in Ayurveda. Its Latin name is Philanthus fraternus. So its decoction of the Bhumya Malki is given in 10 patients, and it is found both of these preparation exhibited hepatoprotective properties compared to the placebo after 12 weeks of treatment on periodic liver function and evaluation. So all these drugs are very effective in active phase of tuberculosis as well as post-tuberculosis sequel also. Treatment is given as adjuvant therapy, but in vitro study, few studies were conducted, and it is also published in IU journal. It is journal published from Jamnagar, IPGT and RA. So in vitro, it is these few drugs mentioned like Adatoda vasica, then sativum, aloe vera. The combination of this drug is given. Aquarius extract of leaves were given in this this in vitro study, and it found very effective in tuberculosis bacteria also. So this study further can help to treat such types of patients effectively and provide the adverse drug reaction. आयुर्वेद के अंदर श्वास व्याधि के अंदर एक एक्टिव फिजियोथेरेपी मेंशन की गई है. इसको हम फिजियोथेरेपी बोलते हैं. जब पेशेंट में लंग फाइब्रोसिस है या फिर पेशेंट में रेस्पिरेटरी सीओपीडी है. सीओपीडी भी दो टाइप का होता है, जैसे ट्यूबरकुलोस सीओपीडी और सीओपीडी ड्यू टू स्मोकिंग इनटू सीओपीडी. इसके अंदर हम जो फिजियोथेरेपी करती है वो थोड़ा मैं श्लोक यहाँ पढ़ के बताऊंगा और फिर एक्सप्लेन करता हूँ. हिक्का श्वासार्दितम स्निग्धेर आदो स्वेदेर उपाचरेत आक्तम लवन तैलेन नाड़ी प्रस्तर संकरे तैरश्च ग्रथिता श्लेष्मा स्त्रोता अभिविलयते खानी मार्दव मायंती तथो वात अनुलोमतः. इसका मीनिंग ये होता है कि अगर पेशेंट को रेस्पिरेटरी डिस्ट्रेस है या फिर वहाँ लंग्स में ऑब्स्ट्रक्शन की वजह से उसको सांस प्रॉपर नहीं ले रहा है, उसका प्राण वायु यानी ऑक्सीजन अंदर नहीं पहुंच रहा है, या फिर एक्सेलेशन उसका प्रॉपर नहीं हो रहा है, तो इस कंडीशन में हम पेशेंट को सेंधा नमक मिला के उसके चेस्ट में मालिश करते हैं और उसके बाद उसको हम सर्टेन मेडिसिन का स्टीम देते हैं. तो उससे उसका लंग जो कंजेशन होता है वो हट जाता है और पेशेंट इज एबल टू टेक द ब्रेथ प्रॉपरली. सो और इसके साथ ही पेशेंट के अंदर जो कफ चिपका होता है जो आसानी से नहीं निकलता वो इजीली एक्सपेल हो जाता है, एंड देन यू फील फ्री टू टेक द इनहेलेशन प्रॉपरली. और ये बहुत ही इफेक्टिव होता है. और अलॉन्ग विद दैट जो ट्यूबरकुलोसिस के कॉम्प्लिकेशन होते हैं, जैसे कि उसको चेस्ट में या फिर शोल्डर में बर्निंग सेंसेशन होते हैं, वो भी इससे रिड्यूस होता है. तो दिस इज फिजियोथेरेपी मेंशन इन आयुर्वेद. ट्यूबरकुलोसिस के पेशेंट का आपको पता है कि इसमें टीबी का जो रेजिमेन होता है 9 मंथ का, वो देने के बाद भी पेशेंट को कंटिन्यूअसली स्पुटम प्रोडक्शन होते रहता है। तो इसके अंदर कुछ आयुर्वेदिक मेडिसिन है, वे वेरी इफेक्टिव है। तो पोस्ट ट्यूबरकुलोसिस लंग डिसीज ये बहुत चैलेंजिंग है टीबी के पेशेंट में, तो हम आयुर्वेद ट्रीटमेंट से इस पेशेंट को हम ठीक कर सकते हैं। देन अगर इनका प्रेजेंटेशन हम देखते हैं तो एक्सरे में अलग अलग टाइप का दिखता है। क्रोनिक ऑब्स्ट्रक्टिव पल्मोनरी डिसीज ड्यू टू स्मोकिंग एंड क्रोनिक ऑब्स्ट्रक्टिव पल्मोनरी डिसीज ड्यू टू ट्यूबरकुलोसिस। इसका डायग्नोसिस करना बहुत इंपॉर्टेंट है। रेडियोलॉजिस्ट को बहुत अच्छे से डायग्नोसिस कर पाते हैं। यहाँ पे मैं एक एक्यूट केस आपके साथ शेयर करना चाहता हूँ कि आयुर्वेदिक ट्रीटमेंट से ही भी एक्यूट पेशेंट ऑफ रेस्पिरेटरी डिस्ट्रेस के हम ठीक कर सकते हैं। ये ड्यूरिंग सेकंड वेव ऑफ कोरोना एक पेशेंट एडमिट था 21 डेज यहाँ पे एक एलोपैथिक हॉस्पिटल में, और ये उसके कुछ रिपोर्ट्स है, सीटी स्कैन का रिपोर्ट है, HRCT आप जूम करके देख सकते हैं। इस पेशेंट का 18 था आउट ऑफ 25। तो सीवियर पेशेंट को तकलीफ थी, 21 डेज ये पेशेंट एडमिट रहा था। उस टाइम आइसोलेशन की वजह से पेशेंट के प्रॉपर रिपोर्ट्स तो हमारे पास नहीं आए, लेकिन जो पोस्ट ग्रेजुएट स्टूडेंट होते हैं हमारे आयुर्वेद के, वो वहाँ पोस्टिंग होने की वजह से उन्होंने ये कुछ रिपोर्ट्स मुझे भेजे थे। तो इस पेशेंट को कंटिन्यूअसली, ये बाईपाप पे पेशेंट था, 13 लीटर O2 इसको रिक्वायर्ड रहता था, और जैसे भी O2 हटाया कि पेशेंट को फिर से डिस्ट्रेस शुरू होता था। तो 21 दिन ऑल मेडिसिन ट्राई करने के बाद भी पेशेंट को रिजल्ट नहीं मिल रहे थे, और नॉट एबल टू इम्प्रूव द पेशेंट। फाइनली उस पेशेंट के कुछ रिपोर्ट्स है, इंटरल्यूकिन वाज इंक्रीज, इट शुड बी अप टू 7, पर इस पेशेंट का 29 था। उसके बाद डी डायमर ऑफ पेशेंट इस पेशेंट का 2000 था, जिसका नॉर्मल वैल्यू 500 होता है। डेंगू की टेस्ट पेशेंट की थी, डेंगू की टेस्ट उसका निगेटिव था। और इस पेशेंट को हमने फिर मेडिसिन बना के उसको अलॉन्ग विद एलोपैथिक मेडिसिन उसको मेडिसिन दिया हमने। सिंपल मेडिसिन है, मैंने क्या मेडिसिन दिया आपके साथ शेयर करूंगा, क्योंकि मोस्ट ऑफ द आयुर्वेदिक स्टूडेंट्स भी इसमें है, और इस कंडीशन को हम ट्रीट भी कर सकते हैं। यहाँ पे मुझे ये हाईलाइट करना था। तो उस पेशेंट को जैसे ही हमारे मेडिसिन का TDS का डोज मैंने उसको दिया था, 3 डोज देने के बाद ही वो पेशेंट, उसका जो ऑक्सीजन लेवल देना पड़ता था वो ऑक्सीजन का कम हो गया, और पेशेंट इनिशियली O2 हटाने के बाद बाथरूम तक भी नहीं जा पाता था, तो वो जाना शुरू हो गया, और धीरे धीरे पेशेंट में इंप्रूवमेंट होने लगा, और उसका कुछ ही दिन में बाईपैप भी हट गया। जो पेशेंट पूरा ठीक नहीं हो सकता था, ऐसा लग रहा था, वो पेशेंट पूरा ठीक हो गया। इसमें सिंपल मेडिसिन हमने यूज किया था, वो था सीतोपलादी चूर्ण। ये सबको पता होता है, इंडियन मेडिसिन है। इसमें आधेतर मेडिसिन जो घर में हम यूज करते हैं, दालचीनी है, एला है, इस टाइप के शक्कर है, ये सब खड़ी शक्कर इसमें मिला होता है। एला मतलब इलायची होती है। उसके साथ श्रृंगार अब्र रस, देन मल्ल सिंदूर, टंकन भस्म, और मौक्तिकयुक्त कामदुधा। अब ये मेडिसिन का क्या रोल है मैं बताऊंगा, लेकिन उसके पहले ये सिंपल मेडिसिन उस पेशेंट को हमने 7 to 10 डेज हार्डली दिया होगा, और पेशेंट का पूरा इंप्रूवमेंट हो गया, और उस पेशेंट को बाईपैप से भी हट गया, और ऑक्सीजन देने की जरूरत भी नहीं पड़ी, और पेशेंट एब्सोल्युटली नॉर्मल है अभी। एक वक्त उनके रिलेटिव को ऐसा लग रहा था कि इस पेशेंट को हम बचा नहीं पाएंगे, लेकिन इस सिंपल मेडिसिन से वी आर एबल टू ट्रीट इन एक्यूट कंडीशन ऑल्सो। उसके बाद जो ट्यूबरकुलोसिस के पेशेंट होते हैं, उनके AKT अगर शुरू भी है तो उस पेशेंट को डिस्निया रहता है, उसके बाद स्पूटम प्रोडक्शन रहता है, हॉर्सनेस ऑफ वॉइस रहता है, और फीवर रखता है। तो इसमें आप सिंपल एक रेमेडी, होम रेमेडी में बताता हूँ, जो अगर देते हैं तो ये सब सिम्टम्स उसके सबसाइड हो जाते हैं। जिसके अंदर खजूर जो होते हैं, अपने खजूर डेट्स वो लेना है, रेजिन्स में मुनक्का लेना है, उसमें थोड़ी पिपली, शहद, शक्कर और घी मिला के उसको पेशेंट को 100 to 200 ml तक का, ये इसको खरजूरादि मंत्र बोलते हैं, ये देना है। तो उस पेशेंट में जो श्वास का ज्वर और स्वर भेद, ये जो सिम्टम्स होते हैं, वो सबसाइड हो जाते हैं। और मेरे प्रैक्टिस के अंदर मैं इसका काफी यूज करता हूँ हमारे पास जब पेशेंट आते हैं तो। उसके बाद एक बहुत चैलेंजिंग सिम्टम्स इन पेशेंट में देखा जाता है, वो है बर्निंग ऑफ हैंड एंड फीट। पाम और फीट के अंदर बहुत बर्निंग होता है, ओवरऑल बर्निंग रहता है पेशेंट में। आयुर्वेद में इसको हस्तपाद सर्वांग दाह बोला है। और इसके अंदर वासाग्रुत, मेडिसिन प्रोसेस्ड विथ वासा, इस अदा थोड़ा वासिका इसका लैटिन नेम है। इसके जो मेडिसिन बनाते हैं, जो आयुर्वेद के अंदर रक्तपित्त यानी हीमोफीलिया जैसा डिसीज है, उस डिसीज के अंदर ये मेंशन किया गया है। दूसरा मेडिसिन है शतावरी, वंडरफुल रिजल्ट्स है हस्तपाद तलदाह के लिए। उसके बाद कभी कभी पेशेंट को लोकल ट्रीटमेंट करना होता है, नॉन मेडिसिन थेरेपी। उसमें आप चंदन आदि तेल मिलता है मार्केट में, उस पेशेंट की मालिश कीजिए ओवरऑल ऑल ओवर द बॉडी, या फिर शतदोत घृत का लेप लगाइए। जो हस्तपाद तलदाह स्पेशली पोस्ट ट्यूबरकुलोसिस या ट्यूबरकुलोसिस के पेशेंट में इसके बहुत अच्छे रिजल्ट देखने को मिलते हैं। उसके बाद टेस्ट, मेटेलिक टेस्ट, ये बहुत चैलेंजिंग होता है। आप इस पेशेंट्स के अंदर ट्यूबरकुलोसिस के पेशेंट में पोस्ट ट्यूबरकुलोसिस सिक्वेल में दे ले लीजिए या फिर एकेटी चल रहा हो तब भी। तो आयुर्वेद में कुछ ऑयल पुलिंग की मेथड बोली हुई है, जिसको हम कवल या गंडूश आयुर्वेद में बोलते हैं। तो इट इज वेरी इफेक्टिव टू चेंज द टेस्ट, उसको टेस्ट अच्छा लगे, वो मेडिसिन ले पाए, इसके लिए बहुत अच्छी रेमेडी होती है। अगर ऑयल पुलिंग किसी को नहीं करना है किसी पेशेंट को, तो एक सिंपल मेडिसिन है, दालचीनी, अजवाइन और बर्बेरिस एरिस्टाटा मीन्स दारू हरिद्रा, जिसको आयुर्वेद में बोला गया है। इस मेडिसिन का कॉम्बिनेशन करके पेशेंट को दिन में 2 या 3 बार देते हैं, हार्डली 2 ग्राम बीडी और टीडीएस। उस पेशेंट का मुंह का जो टेस्ट है वो अच्छा हो जाता है, और उसको मतलब जो एनोरेक्सिया होता है, जिसकी वजह से पेशेंट खाना नहीं खाता है, मेडिसिन नहीं ले पाता, कभी बहुत से बार वो पेशेंट मेडिसिन एकेटिस बीच में ही स्टॉप कर देता है ड्यू टू दिस नोसेटिंग फीलिंग। तो उसका प्रॉपर मुंह का टेस्ट रखने के लिए इट इज वेरी इफेक्टिव मेडिसिन, और ये ऑलमोस्ट घर में मिलने वाली ही मेडिसिन है। उसके बाद आयुर्वेद का एक ग्रंथ है जिसको हम रस तरंगिनी बोलते हैं। उसका अंदर एक श्लोक आया है, मैं इंटेंशनली आपके साथ शेयर कर रहा हूँ। उसमें लिखा है, मृत विद्रुम संयुक्तम मौक्तिकम परिशीलितम हंति फुफ्फुस दौर्बल्यम चीरकाल समुद्भव। यानी क्रोनिक डिसऑर्डर्स के वजह से आपके लंग्स में अगर वीकनेस आ गया हो, वहां फाइब्रोटिक चेंजेस हो, या फिर पेशेंट का लंग्स प्रॉपरली फंक्शन नहीं कर रहा है, तो ऐसे कंडीशन के अंदर प्रवाल और मौक्तिक इसका कॉम्बिनेशन दीजिए। मैं मोस्ट ऑफ द पेशेंट में ट्राई करता हूँ, इवन लंग फाइब्रोसिस का पेशेंट जिनको रेस्पिरेटरी डिस्ट्रेस रहता है, उन पेशेंट्स के अंदर भी इट इज वेरी इफेक्टिव मेडिसिन। इट इज हर्बो मिनरल प्रोडक्ट। प्रवाल मीन्स कोरल एंड मौक्तिक मीन्स मोती जो होता है अपना, उसका भस्म इसको नैनो पार्टिकल्स के अंदर कन्वर्ट किया जाता है विथ सर्टन आयुर्वेदिक हर्ब्स, एंड देयर आफ्टर इट इज गिवन टू पेशेंट इन वेरी लो डोजेस, एंड इट इज वेरी इफेक्टिव इन lung fibrosis like condition or any condition in which lung is involved. तो लंग फाइब्रोसिस अप टू सम एक्सटेंट आयुर्वेदिक मेडिसिन से रिवर्स हो सकता है। ये प्रैक्टिकली हम प्रैक्टिस में देखते हैं। कई अभी पोस्ट कोरोना की वजह से कई पेशेंट रेस्पिरेटरी डिस्ट्रेस के हमारे पास आते हैं, तो उसमें हमने ये किया है कि उनका जनरली ड्राई कफ हो जाता है, और ड्राई कफ के अंदर कुछ भी मेडिसिन काम नहीं करती है। तो उस वक्त उस पेशेंट के अंदर हम सिंपल प्रवाल और मौक्तिक युक्त कामदूदा इस टाइप के मेडिसिन जो हम यूज करते हैं, तो वंडरफुल रिजल्ट देखने को मिलते हैं। जो 3-3 महीने मेडिसिन लेके पेशेंट को रिलीफ नहीं मिलता है, वो रिलीफ उस पेशेंट को ये सिंपल मेडिसिन से, एसटी मधु, प्रवाल और मौक्तिक इस मेडिसिन से हमने देखा है। विद इन 7 डेज उनका जो ब्रोंकाइटिस रहता है वो पूरा ठीक हो जाता है। ब्रोंकिएक्टिसिस ये एक और कंडीशन है जिसके अंदर हम आयुर्वेद के अंदर प्रवाल मौक्तिक युक्त, देन शुंग भस्म, तालिसादी चूर्ण और कंटकारी अवलिया के साथ ये मेडिसिन देते हैं, तो इसमें बहुत ही इफेक्टिव देखा जाता है। उसके बाद एक जो हिपेटोटॉक्सिसिटी डेवलप होती है पेशेंट के अंदर, उसके अंदर एक मैंने जो इसके पहले बोला था भूम्या मलकी का क्वाथ, और सेकंड इज वर्धमान पिप्पली रसायन। इसके अंदर जो पाइपर लॉन्गम नाम का जो मेडिसिन होता है, जैसा लैटिन नेम है, पिप्पली सबको पता होता है इंडियंस को मोस्टली, जिसके अंदर एक पिप्पली से शुरू करना है, मिल्क के अंदर बॉईल करना और पेशेंट को देना है, फिर सेकंड डे 2, देन थर्ड डे 3, ऐसा 21 डेज तक उसको इंक्रीज करना है, एंड देन 21 to 1 तक उसको रिड्यूस करना है। ऐसे 3 साइकिल उस पेशेंट में अगर हम देते हैं, तो इस पेशेंट्स में हमने देखा है कि हिपेटोटॉक्सिसिटी कम होते हुए प्रैक्टिकली देखा है। और ये फिजिशियन के अंडर ऑब्जर्वेशन ही होना चाहिए, आयुर्वेदिक एक्सपर्ट ने ही देना चाहिए, उसकी कुछ कॉम्प्लिकेशन भी हो सकते हैं। आयुर्वेदिक ड्रग सेफ है ऐसा नहीं है, तो हम कंडीशन पे डिसाइड करते हैं। जनरली वात पित्त कफ उस पेशेंट में क्या डोमिनेटेड, अकॉर्डिंगली हम पेशेंट को मेडिसिन सिलेक्ट करते हैं। और आयुर्वेद में जब भी रेस्पिरेटरी पेशेंट ट्रीट करते हैं, तो उसमें हम ध्यान रखते हैं कि आयुर्वेद में एक श्लोक बोला गया है, उरास्तः कुरुते श्वासम आमाशय समुद्भवा पित्त स्थान समुद्भवा। वाग्भट निदान स्थान में ये बोला गया है कि ये जो रेस्पिरेटरी डिसीज है, दो उसका मैनिफेस्टेशन लंग्स में दिखता है, लेकिन इसका जो इनिशिएशन है, स्टार्ट है, कफ का जो प्रोडक्शन है, वो आमाशय यानी स्टमक में होता है। इसलिए रेस्पिरेटरी सिस्टम के साथ साथ हमको आम पाचन है, अग्निदीपन जैसी मेडिसिन हमको देना पड़ता है। और लंग फाइब्रोसिस के अंदर वात प्रधान कंडीशन होती है, तो इसके अंदर हम घृतपान करते हैं, मतलब सर्टन मेडिसिन प्रोसेस घी पेशेंट को देते हैं। तो प्राण व स्तोतस की यानी रेस्पिरेटरी सिस्टम की जो मेडिसिन है उसके अंदर कुछ रसायन मेडिसिन है, जैसे अभ्रक भस्म या श्रृंगार रस, इस टाइप के मेडिसिन हमको यूज करना पड़ता है। वहाँ जो एक प्रकार का इम्यूनिटी कम हो जाता है, उसमें ओझोवर्धक मेडिसिन हमको देना पड़ता है। प्राण व स्तोतस की बलवर्धन करने वाली मेडिसिन हमको इस पेशेंट्स में यूज करना पड़ता है। So while treating the respiratory system disorders, it is very necessary to keep in mind the digestion and metabolism of the patient. Also, the constipation patient suffers more from these disorders. So उसका constipation भी correct करना है। आयुर्वेद में concept पंचकर्म में बोला है अनुलोमन चिकित्सा, तो उसकी वजह से उसका प्राण और उदान वायु ठीक होता है और patient ठीक हो जाता है। तो whenever we are going to treat the patient of respiratory system, we have to consider all these factors. सो अगर ये सब पॉइंट हम ध्यान में रखते हो तो वे आर सक्सेसफुली और सेटिस्फैक्टरीली हम पेशेंट्स को ट्रीट कर सकते हैं। सो दिस इज ऑल अबाउट माय प्रेजेंटेशन। So thank you very much all the participants for patience listening, and thank you MHS organizing team for inviting me to share my views regarding respiratory system and role of Ayurveda. Thank you, madam. Thank you very much.
Yes, sir. Yes, sir. Very nicely explained. You have actually ना बच्चे लोग PubMed वगैरह ये आर्टिकल से ज्यादा go through नहीं होते हैं, तो you have showed the evidence based result to them about the respiratory system पे आयुर्वेद कैसे काम करता है। So actually, as our honorable VC is looking forward and expecting the integration of the all the pathies, IUL department has taken this initiative obviously under the guidance of honorable VC.
I would like to congratulate MUHS for this initiation.
Yes,
the integration is a
yes,
time
thank
of need.
Yes, actually we have completed many areas like diabetes mellitus, antenatal care, pediatric, musculoskeletal disease, and now we are moving through the respiratory system. Today's case was presented by Dr. Mansi Deshmukh. She has been the physiotherapy student, and I should appreciate her since she is physiotherapy student. She has presented the case very well with the evidence, with the evidences of the HRCT and all the ABG reports. Then we were having our today's expert, Dr. Komal Shah, and I should congratulate and thanks her. Instead, she is being the pulmonologist. She has explained the respective lung disease in very simplified manner. And also today's our second expert, Dr. Jogad sir. Dr. Jogad sir has thrown the light of the Ayurvedic, throw the light on the respective lung disease by the means of Ayurvedic medicines and detail. And he has explained the COVID cases also. Now this is all done about today's topic. And if the participants are having any questions, then questions are welcome.
त्याच्यामध्ये तुम्ही जेवलेली ना त्याच्यामुळे तुमचं हे झालं.
The session is open for question and answer. If anybody is having any doubt, Dr. Komal Shah is with us, Dr. Jogad sir is with us, so they may give answers to your questions successfully. So I think there is no doubt from the side of participants. So I extend my thanks to all of you, all the participants, on behalf of Dr. Karle ma'am and on behalf of Maharashtra University of the Health Sciences. And I declare that the meeting is over. Thank you, all of you.
Thank you, ma'am.